Dr. Bhatnagar is an addiction psychiatrist at UW-Madison. She worked in specialty addiction treatment settings in the community for more than a decade and is now Associate Director of Psychiatric Services at University Health Services at UW. She's also a clinical associate professor in the Department of Psychiatry at UW and very actively involved with FASAM and the Suicide Prevention and Harm Reduction Task Force and on the advisory board for the Wisconsin Alcohol Policy Project. So Dr. Bhatnagar, I will let you share and we'll go from here. That looks good, but you're muted.
Okay, how about now?
No, you're good now.
Okay, the other thing before we leave off the case, I was really curious about the fact that the bupropion stayed at 150 the whole time, and then other stimulants were added in addition, and wondering about other non-SSRI agents for the anxiety as well. And anyway, lots of questions remain. So, but we'll continue that, and I'll allow myself to mentally pivot to the talk that I'm going to share with you now, which is going to continue this conversation. So in terms of what we are going to be I think it actually dovetails very well with the case here, which is very convenient. Thank you, Carrie, for setting that up from the time when the person started using, because it really does have an impact on developing brain. And then I want to review just some quickly cannabis impacts and trends, some attention confounders, and then clinical considerations in case you are in the situation of trying to treat both the ADHD and cannabis use, or somebody wanting attention help when they are struggling with cannabis use. So no conflicts other than a WSAM grant. And then I want to really focus on diagnosing ADHD accurately, which is sort of the holy grail, I think, of all of this to some extent as we go through. But so some nice pictures to demonstrate that there's just a lot going on in the brain between birth and adulthood, but also specifically between birth and the age of 6, there's the brain quadruples in size. And then between young child and teenager, there's still a ton going on developmentally. And so what's really important to be aware of what's happening developmentally during this time period. So synaptogenesis is really at its peak in that in utero up to age 2. But if we look at the other things that are happening in the brain during this time, during the lifespan, synaptic pruning is at its peak during the adolescent period. And that, I think, is really where it's important to think about the impact of substances on the brain in general, but in particular with respect to attention. So what is this? It's really this method for removing synapses that are not often used. It's a natural process. At age 2, we have like 15,000. By adult age, we have on average 8,000. But it just takes too much energy to keep them all intact. So what this process is just kind of cleaning up the neural network to improve efficiency and refine the brain function. So we can strengthen the ones that are actively employed, and it makes this more efficient. And there's evidence that occurs during sleep, which explains perhaps the increased need for sleep during adolescence as well. But it's a vulnerable time developmentally, because this is the other stuff that's happening during this time, is that there's emergence of symptoms for mental health, as well as you can see the autism, schizophrenia. Sorry, I didn't describe what those were. ASD, autism spectrum disorders, schizophrenia is the SC, and Alzheimer's is AD. So it's really one of the major peaks during adolescence where we start to see the emergence of many mental health symptoms and illnesses that may then become that way. And they are obviously impacted by the environment as well. So no divergence here from what is sort of presumed and understood, but it's important to kind of name that out loud. And this is why we should really care, because people are most likely to begin misusing drugs during adolescence. And the longer adolescents can defer experimentation, the less likely they are to develop long-term substance use problems. We know that when there is an impact on the neurons during this time of synaptic pruning. So this would be in nature. You can think of it just sort of like with little trimming shears, but then with substance use on top or other environmental insults, that can be, you can think of it kind of like having a chainsaw take out more than is perhaps needed developmentally. And if even worse, like in a lightning storm of some kind. So dramatic pictures, but really just trying to bring home the point that it's really important to think about what's happening during this developmental period. We know that chronic cannabis use that begins in childhood or adolescence can be associated with long-term impairments in attention, concentration, impulsivity, long-term planning, intellectual ability, and executive functioning. So all the things that we kind of think about also with ADHD, right? So it can be really hard to distinguish between the two. We also know that 9% of people who use cannabis regularly become dependent on it, and it rises to 17% in those who start using it during adolescence. So I want to just take a minute then to look at the cannabis itself in society right now very briefly. This is like back from the 60s and 70s where the discussion changed. Used to be reefer madness and Mexican rapists and this whole really social stigma piece to it, to now more being much more socially accepted. And social media has helped significantly with the aid of big marijuana to support them in their endeavors to just really make this a much more socially acceptable substance. And so it's in short big business, and they've been really effective with changing the perceptions of risk, and subsequently there's availability that has increased as well. There's lots of studies that have looked at the decreasing perception of harm among adolescents as well, and that continues to, not surprisingly. We have seen legalization spread across the country, with surrounding states legalizing it, like we've just talked about. It's really readily available. So it's a very common issue. As you just heard from Carrie, this is what people are asking for help most commonly. So what about the trends overall? From the 70s, we did see a significant decrease to the 90s, but then it started to increase back up, unfortunately. So this takes us up to 2016, where we see men again using more often than women. This is for ages 12 to 25 that we see, but in more recent data, and this is specifically for high school, the sources of here, this is from Monitoring the Future surveys, so really good, solid sources of information for this. But you can see that it, in the 90s kind of had a little spike, and then where there were about 50% of seniors having sampled, now it's still, through the pandemic, we saw with every substance, but cannabis also, it decreased for trends, but then it's kind of come back up a little bit, staying into about the 35% range for seniors, and eighth graders still in around the 10% range. It is the most commonly used illicit drug, some with availability, but also the social acceptability piece. And unfortunately, over time, this is something that does not get talked about quite as much in the big marijuana sort of marketing and advertising. The concentrations of THC in the average cannabis specimen that's been, this is from DEA sources, and that was 2014. So it went, it was found to be like in the 12, 13, 14% range. Now it's been the 20 to 30% range for plants, and up to 70 to 80%, depending on the form. There's a lot of variability in what's out there and what's available. High potency is considered greater than 10% THC. So pretty much all the THC plant material that's generally out there is now high potency THC, whereas low potency is less than 10%. So if we contrast that to the potency in like the before common era, so from some of the sort of mythological time periods and so on in ancient cultures, that was less than 1%. So in terms of that use and how it was portrayed and accepted versus what we're seeing now, it's not really the same substance, I would argue. And so it's really hard to consider what the impact proposed back then compared to what we're seeing now. And so what about what we're seeing now in youth, and one of the other wonderful sources is the National Survey on Drug Use and Health, which I'm hoping will still be continued in this current era. But this is the most recent data I could find from 2023, this survey, and this looked at the types of marijuana use. So really just breaking that down. And you can see in that 12 to 17 and 18 to 25, so this developmental piece that we're talking about, it's higher for marijuana vaping. And that is concerning, particularly to me when I think about it, because the vaping concentration, the oil is usually 70, 80 or more % potent. THC, you can vary. I mean, obviously there's a lot of variability, but the average when I'm talking to people that they're getting is this, without looking at the potency, that what they're ending up with is between 70 to 80%. And so it is definitely something for us to be really aware of and have as part of the discussion. So the effects of this that we want to think about chronically, there's acute and there's chronic effects. I added increasing SI to this from the slide set that you have, but it's important to kind of keep that in mind too, that there's the attention pieces people are aware of, but in terms of the mental health aspects, there are significant consequences to chronic cannabis use that have been studied. It's challenging to study, right, in this country because it's a Schedule 1 substance. But even despite that, there have been studies in this country, other countries, Canada, Australia, New Zealand have some really, really good studies that have been done and really looked at this pretty closely and found these associations. Everything, people say that it helps my anxiety. Well, some people say it actually worsens their anxiety. And so if it seems to be that if there's an underlying anxiety disorder before they start using, it's really not recommended to use cannabis in its current form. We can have some other side discussions about CBD content versus THC content, but CBD is its whole different entity than the THC that has been linked to the psychoactive aspect of the cannabis effects. So that's certainly what we want to be thinking about. Physically, people often sort of overlook this, but more recently, this is 2025 that just came out about cardiovascular effects of cannabis as well. So if you think about that, plus some of the effects of other things, substances that are out there and things that people are using to treat attention, it becomes a more relevant discussion as well. So association between schizophrenia and cannabis use, stronger in young men than women. And then this particular study, the last one here, is the Dunedin study, which came out of folks in New Zealand that really did a lovely long-term prospective trial. And they've looked at individuals, about 1,000 of them that were born in 1972 to 1973 and followed them to age 45 with like a surprising 94% retention rate. This is fascinating. But this is the last study that I'm referencing here, and it demonstrated that all things being equal, they looked at and found evidence of poorer learning, memory, and processing speed with respect to chronic cannabis use than long-term or alcohol use. And so this is just one version of some of the results that came in, but it showed an average reduction in IQ, but it also showed these cognitive deficits that could not be explained by persistent tobacco, alcohol, or other illicit drug use. Childhood socioeconomic status, low childhood self-control, or family history. It's just pretty dramatic stuff that you start to see it when you're looking at it over the time frame, over the lifespan. And it showed smaller hippocampal volume because they were looking at fMRI as well, and PET scans, and then looking at smaller hippocampal volume did not statistically mediate the cannabis-related cognitive deficits, but these midlife cognitive deficits and smaller hippocampal volume are increased risk factors for dementia. So I'm curious to see, as the potency increases over time, what happens. So back to cannabis attention for the rest of the talk here. The high doses of recreational cannabis, we know acutely, it would result in this temporary disruption of short-term memory. That's pretty well known, and I don't think people need to study that too much, but memory, fortunately, seems to return to normal with abstinence. But with chronic use, what we're finding is that we see this diminished concentration, which actually looks a lot like an ADHD inattentive type, and with more impulsivity as well. as I mentioned before, people with ADHD are very much more likely to try substances. This novelty-seeking aspect of ADHD is certainly something that we are aware of, but it's because they're trying it, they're just much more likely to develop cannabis use disorder as well. Sort of that two-hit hypothesis if they are already vulnerable to it anyway. But they are people with ADHD 3 times as likely to use it, but more than half of daily and non-daily cannabis users have been diagnosed with ADHD anyway. So this is it kind of goes both ways in terms of how we think about it. So if we are really thinking about it from an attention and a learning standpoint, like with our case, we would want to focus on the fact that the cannabis use does, impair the ability to learn. I don't think there's, the jury does not seem to be out on that one. That one is definitely a known correlation and causation, I think is fair to say at this point. So this was a study that was done with young folks ages 13 to 18 that were being assessed for substance use disorder treatment. And they were asked, why are you using cannabis? And the first 6 things were from that study. The last 2 are more my social commentary and other noticings. So you notice that when people said they're using cannabis from this population, helping them pay attention was not among that list. So I think it's really important to ask people why they're using what they're using and see if we can help them target those things in other ways as you're supporting them through figuring out what to do about their attention. And when people say it's natural or safe, my response to that is it's like having them understand that this is no longer in its natural form, kind of referencing back to that increasing potency discussion before. And the irritability piece, like in Carrie's case, it does lend credence to the diagnosis of cannabis use disorder and certainly fits. It has been characterized. There was for a while a lot of discussion about, is there actually such a thing as a cannabis use disorder? Again, I think that has been put to rest. So we can use the same criteria and for diagnosing substance use disorder and absolutely treat it as such. So it's also a way to address the myths, I think, that people come in with, saying they can't come in being, I can't be addicted to this. This is just a natural thing. So there are many different types of distraction. And I think when I just had this happen yesterday with a student that I was seeing where they wanted help with their attention, and I really had to like drill deep and try to figure out what else is going on in your life. And so it takes time, ultimately. The point is that it can be a combination of many of the societal things that make it easy for us to not pay attention to what's happening around us. The digital ones are the most often commonly seen ones. Mental health and comorbidities are clearly there. Sleep is something in college students, right? Everybody's like sacrificing sleep to study, but it has the opposite effect then of impairing their attention. And so then they're just like chasing their tail, trying to figure out which stimulant can help them stay awake the longest and perform the best. I've even had some students use nicotine as a stimulant, like in a patch form, to try to stay awake, or with the pouches. So lots of things going on. There could be learning disorders, and so it becomes ultimately this diagnostic challenge. And how do you, as a clinician, with perhaps not as much time, try to figure out what to do, knowing that there's impact on motivation and planning, goal setting, and achieving if it's not treated? The attention at this developmental point in their lives is critical, that they are able to focus on what they want to focus on. So these are these dilemmas, because we know that untreated ADHD symptoms can be associated with increased substances of any kind, including cannabis, and that effectively addressing the ADHD symptoms can decrease the risk of substance use and improve substance use treatment outcomes, including everything that you've seen here, and including death, because like suicidal ideation is a risk factor, or that travels with ADHD. Oftentimes as well, along with all of the other concomitant mental health pieces. So interestingly, the cannabis use on like Reddit Substacks and stuff, people are talking about using cannabis to treat their ADHD symptoms. But what they're saying they're using it to treat is anxiety, rejection sensitive dysphoria, and poor sleep, which again, I would argue are not really ADHD symptoms in and of themselves. And so I think it's worth being very, very thoughtful about the diagnosis, because these things can occur with other mental health conditions as well. And so neuropsychological testing is very helpful, but saying that, I fully 100% recognize this is hard to access complete testing in a timely way. There are more options online, but they're also not particularly appropriate quality, and some are asynchronous, and you can just pay a couple $100 and take as much time as you want to answer these questions, and then they'll come back with a diagnosis for you that isn't entirely valid and not, I don't think it's getting at some of the executive testing features anyway. So it is, the symptoms of ADHD are largely subjective in nature. They're available online. You can know the criteria, you can answer it that way. And so, not surprisingly, there's been an increase in the diagnosis of ADHD, doubled from 1997 to 2022. Again, sort of like, are we really, there's something that is this more of a societal issue versus a brain issue? So it's in this sort of time frame, in the 20-year time frame, I'm finding that a little bit harder to believe. So opinionating aside, I guess what we're seeing is with increasing diagnosis, we do see increasing use of stimulants, and we have to be aware of the diversion and misuse risk, which is why we're talking about the urine drug screens and the reason to use that in our practices appropriately. So because the stimulant diversion and misuse risk is very real, in college age students, it's absolutely a concern. At UHS, we have a very specific, strict policy on prescribing stimulants for ADHD for exactly that reason. There's diversion as well, which is a concern, with up to like a third of students saying that they have this is self-report too. So this is taken with that. The people who are more likely to divert fell into these categories according to this particular study. And so what we want to do then is figure out, as we're doing this, how do we decide what to do? So we want to try non-stimulant options first, especially when there's co-occurring disorders. For instance, guanfacine, when there's attention issues, anxiety, and PTSD. If there's nicotine use disorder, we can think about bupropion, atomoxetine, viloxazine, that's the trade name Quellbri. Prescribe what's needed. Stimulants are okay, but make sure that you have your own sense of what is appropriate for you as a prescriber, that there's going to be a lot of demand for people to prescribe, but you need to decide what's appropriate for your practice. There are benefits, as we've said, to proceed with stimulant treatment. And if you decide to, we've talked about, like in Carrie's case, encouraging abstinence versus requiring it. And using these non-judgmental approaches. They're long-acting stimulants if you decide versus non-stimulant medications to reduce the misuse risk. Regular screening for and treatment of. I have used shorter prescriptions if I've got a particular concern. So I might use every week or 2 weeks, like you might with buprenorphine, just to help engage people a little bit more in treatment and talk to them more often about what they're experiencing, and then using obviously the PDMP, routine drug tests, and family therapy. So the folks up in Canada, it's been legal there since 2018 on a national level. So they've developed some really cool resources that I just wanted to share. And it's got this really nice interactive animated feature about what your brain does on pot. So it's kind of cute and fun to watch if you want to take a couple minutes. It also talks about the endocannabinoid system, which doesn't get talked about near enough as part of why we care. And Carrie talked about some of the medications that can help with reducing the impact of cannabis as people are the withdrawal symptoms. That tea break, the tolerance break, is really nice for students who are just thinking about it but want to know what might it be like if they stopped. I've used gabapentin and clonidine, again, mostly off-label, to figure out what we can do. So here are my conclusions, and I know we are at time, so I guess I did use all that time.